Good morning, and thank you for joining this morning's NJCAR webinar, Cost Containment Strategies and the Current State of Employee Health Benefits. I'm Brian Hughes, Director of Communications at NJCAR. Today you will hear from Bruce Mazzarelli of HUB International and Lou Young of Withum, as well as John Milne and Ward Bauman of Corporate Synergies. Lou will begin the webinar with a very brief overview of the latest NJCAR Health Benefits Report, but the bulk of the presentation will focus on a variety of important issues that cover the current state of employee health benefits and how dealers can try to contain their health benefit costs. It also will address how COVID-19 has affected things, since this report was conducted, the survey and the report were conducted prior to the world changing drastically. They will be addressing that in the next 45 minutes. Before we begin, I just have a few quick housekeeping details. On the right-hand side of your screen is a control panel. I'd like to point out the questions tab in particular. During the call, all participants will be muted. If you have a question during the presentation, we ask that you write it down. We'll give you a 5-minute heads up when the webinar is winding down, and you can submit your questions in the questions tab, or if you'd like, you can raise your hand. I believe there's like a hand raising icon there, and we're going to try something a little different. We are going to try to unmute people and let them ask them live. That doesn't always work, so if we don't hear you, we may ask you to submit the question in writing and move on to the next person. So we apologize ahead of time if there's any technical issues at the end, but we're going to try that a little differently. So now I'd like to turn things over to Lou to kick things off. Lou?
Thanks, Brian. Good morning, everybody. Today, as Brian mentioned, we're going to go over the slides for the data that we collected for the 2019 survey. Again, as Brian mentioned, these are all pre-COVID results. So we will be talking about some current affairs, current issues out there, but we do want to go through the results prior to that. So just kicking it off, looking at a summary of the results. This is our 6th annual. It's hard to believe that we've been doing this that long. We looked at 135 dealerships, which is pretty similar to previous years. And for the 4th year, we were able to capture the results using an online survey tool. So we now have pretty good data over the last 4 years, consistent results, and you'll see that we have some good, some nice time trends. Just in general out there, we saw more than half of the dealership groups offering 3 or more plans. We saw a reduction in the market share for Horizon. We'll talk about that in a little bit. Ancillary benefits were pretty steady. And the big news, I guess, is that we saw a low renewal increase. In most cases, it was less than 5%. And again, the other thing that we saw, the trend that we're starting to see in the last few years, employee contributions are down. So we're pleased about those two things. And again, the beauty of the survey now is that we have some solid years, 4 solid years. So this is our market share summary. You can see the trends here. Again, as I mentioned, Cigna and Aetna are up, Horizon's down, and we're starting to see some of the that we talked about last year. The programs we talked about last year, level funded programs, have increased for Aetna and Cigna, so that may be taking some market share away from Horizon. And again, we saw the HDHP drop a little bit for the first time. That's been going up. So the high deductible plans seem to come back a little bit this year. I don't know if there's a reason for that. Ward or or John or Bruce, if you want to jump in anytime and talk about whether there have been any changes out there that would reduce the HDHP, you can. But you know, again, the rest of the data is pretty steady.
Yeah, Lou, I think that one of the reasons for that is that the same reason you saw a decrease in Horizon utilization is the level funded programs that are available out there. So organizations are able to continue with the traditional copay plans and PPO plans that they had in the past without having to migrate over to one of the high deductible plans, in my opinion.
And I think there's probably a second event that's happening here. As you mentioned as part of the summary, we are starting to see some of the employees' costs come down. And so ultimately, I think the high deductible health plan, when we're seeing large renewals and employers are putting in a high deductible health plan as an option with much lower payroll contributions, you see migration. When we're asking the questions within the, within the tool to capture the data, we say, what's the most popular plan? So it's also possible, and I certainly agree with what John said, but it's also possible that as a result of payroll contributions coming down on the non-high deductible health plans, it's possible that folks are migrating to a more traditional coverage because now it's more affordable than it may have been in the last couple of years.
Okay, great. And as you can see, this chart shows us that we are seeing the lion's share of the renewals less than 5%. So that's great to see a drop off. We'll see what happens in 2020, but for now, we are seeing the reduction in the renewal increase, the rates of increase. And some of these things I mentioned, we saw a significant increase in employers contributing 50% or more towards premiums. The percent of employers contributing 75% or more is at its highest level since 2016. And less than 30% of the respondents indicated a contribution of less than 50% compared to previous, the previous 3-year average of 47%. So that, again, all good for the employees, all good for the industry. And here we have the premiums by tier: single, couple, parent, child, family. And as you can see, very level across the board, with slight increases for single, parent, child, and family, and pretty much the same, little down for a couple. And again, this would indicate the nice increase in employer contribution, 50% or more. You can see it's well above previous years. That's great for the employees, and the employer share, again, is up slightly for all except the couple. And this one we see employee share basically level for single, but down for everything else in terms of looking at the 4-year average. So it's good to see that, you know, we're finally seeing some leveling off for the cost to the employee. I want to get to the other presenters, but generally we have been talking about the employee's cost. We saw lower doctor copays and less exposure in the event of a large claim, reducing barriers to accessing care. 2019 was a very good year in terms of the increases, as we mentioned, and I guess fewer employers were forced to reduce benefits or implement the HDHPs. So that's good. We continue to see employers demonstrating an ability and a desire to increase their portion of overall premiums to the highest level since the survey's inception. The plan designs saw minimal changes. We continue to see the popularity of these HDHPs and the self-insurance. Co-pays, prescription coverage, maximum out-of-pocket expenses have remained relatively constant in the past few years. What we talked about earlier, we added a few questions this year to get responses from our survey takers to see what topics they were interested in, what they would want to hear more about. And then rather than focus on just the survey results today, we wanted to touch on some of these topics that were of most interest to the respondents. As a result, I'm going to turn it over to John and Bruce to focus on these topics, but also to focus on some of the topics that are current, especially with the coronavirus and some of the things we have seen in the past few months. So with that, I think Bruce, you're going to take it first.
That's correct. Thank you, Lou. So we're going to go ahead and talk again, really, what's the impact of COVID on employee benefits? And we talk about the current state, certainly a very fluid situation in terms of what's been happening out there. And I won't go so far as to say, forget everything Lou just said, because as a result of COVID, everything in the world is changing in the world of employee benefits. But what I would say is we do have to pay careful attention to what the impact is, those things that have changed, some of which have created challenges, some of which, frankly, have created some opportunity. And so when we talk about the impact of COVID-19, perhaps one of the first topics that was addressed, and probably still the topic that created the most phone calls for me as a broker working with clients, is the change as a result in terms of eligibility and participation rules. And again, I mentioned challenge versus opportunity. Well, this really created an opportunity and allowed employers to keep employees on the plans, even if they were not actively at work. Generally, that's referred to as a furlough as opposed to a layoff. And in that situation, the carriers basically took away the actively at work clause. And what the actively at work clause generally said, in order to be covered under the active plan, you need to be physically at work. Well, because that was relaxed, employers were able to continue to cover in terms of medical benefits, dental benefits, et cetera, even though the employee wasn't physically at the location. And so it also created an opportunity to allow you to collect some of the premium. And so, you know, employers generally were continuing to pay their portion of the premiums and ultimately expect to, at least at some point in time, collect the employee's portion. And we'll talk about that in a moment. But again, that really created some opportunity to do the best thing for our employees. Hopefully, you know, particularly our best employees, having them covered during the time they're off, they'll be more likely to return to work and continue to be effective. So I do think that that's an important component, and we'll talk about it a little bit more as we kind of go through the presentation. So in terms of benefits coverage, one of the big changes in terms of insurance companies, and this is specific to insured business. So if you're in an insured program, the medical carriers are required to cover 100% of the treatment costs, even in a high deductible health plan. So as you may be aware, a high deductible health plan generally requires that there's no first dollar coverage outside of preventive care. This change allowed carriers to cover COVID-19 treatment costs, diagnosis, et cetera, at 100% and not really interfere with that relationship of a high deductible plan. So those claims remain eligible even though there was first dollar coverage. In general, we're talking about testing, diagnosis, and treatment, again, required if you're in an insured program. Generally, it's discretionary in a self-insured program, and that may vary with some of the level-funded carriers. They may be dictating how that's covered, but generally in self-insurance, while you were required to cover the testing, you were not necessarily required to cover diagnosis and treatment. So just some food for thought. The other thing that's interesting, I think when you take a look and folks think about what the impact to claims would be, I think most folks' initial reaction was, well, this is really going to hurt renewals. There's going to be a tremendous claims impact in terms of all these COVID cases. We're seeing examples of folks in the hospital for 75 days, et cetera. The fact of the matter is most people, including HUB International and several other brokers, have taken a look at this and generally expect, at least short term, the impact of claims to be between a negative 1%, who would have thought that, to a positive 2%. And certainly it's too early to tell, but also I think everyone recognizes that when you take a look at hospitalizations or claims that may have been coming in, the fact is elective surgery in many cases was not an option. So someone who perhaps would have had some work done on their knee put that off because they didn't have the opportunity to have those services provided. You think about going to the doctor. Very, very often somebody's putting that off to a future, to a future date. So claims are being pushed back. The actual impact of COVID itself, again, is expected to be relatively mild, but I think that the carriers, because it's too early to tell, are going to really be conservative in renewals. So when we were talking earlier about the 2019 results of the survey and looking back to the prior years, my initial experience in terms of renewals has been a little bit higher than what I've seen in the prior years. John and Ward, do you want to comment a little bit about what you're seeing in terms of renewals in this period?
Yeah, I mean, I'm seeing the same. I mean, I think that carriers are, holding pretty tight in terms of the increases because, I think that, they're afraid to lose a little bit of business. And I think that they are seeing that, the decrease in claims utilization because of exactly those reasons. There's obviously an uptick with COVID-19 cases, but any elective surgeries, a lot of hospitals weren't even taking them for a period of time, so pushing them off to either later in this year or even early next year as well. So I think we're going to see some, like you said, a mild year in terms of increases, which does scare me a little bit for 2021 though. So that's where I think we're kind of punting this down the road a little bit, and 2021 is the year that I'm a little bit more concerned with.
Well, fair points, and I definitely agree with the comments. I do think that it is going to be interesting. Oh, I'm sorry, Ward.
Yeah, let me add one thing to that is as the carriers' loss ratios are coming in much lower than what they would have expected in a normal year, I think the groups are going to start to see some rebates under the Affordable Care Act. And I think it's everyone should be prepared to, if you've never received one of these rebates, to be prepared on how and what the rules govern on how you can share or you should share these rebates with the staff.
And that's a great point, because I do think you're going to see an uptick in carriers having to provide rebates. I would point out through this presentation, we are going to talk a little bit about credits, premium credits, as opposed to rebates. But there's a tie, and we'll talk about that. So, it is a great point. Some carriers more consistently have provided rebate checks. Oxford comes to mind. But to Ward's point, claims are down, and, I don't know what the impact's going to be on renewals yet. I do think the fourth quarter will be a little bit more relaxed than what I'm seeing right now, but it will certainly have an impact in the future. So to continue through the slide, dental claims are down significantly. I think we can all understand why that's the case in terms of that setting not really being effective in terms of virtual visits, and also folks concerned about contracting the disease. Those claims are down significantly, and the carriers are responding accordingly. So one of the things I do want to point out, and I hope this is one of the takeaways in terms of what we're talking about today, is the fact that plan marketing is extremely difficult right now. So I was having a conversation with one of the executives at United Healthcare yesterday, and just trying to get a sense from them what their marketing of the plans. So in other words, if I'm with Horizon Blue Cross Blue Shield and I want to market the plan to Oxford, what is that looking like? What are you seeing today? Well, quite frankly, their quote activity is down significantly. And I think there's a couple reasons for that. This is probably not the best environment for change. We can understand that. But there also are some difficulties just in terms of how we prepare a quote for marketplace. And the biggest challenge, as everyone I'm sure on the call can recognize, is the census itself. So there's been significant changes to probably everyone on this call in terms of their census of eligible employees. And so as a result of that, it becomes very difficult because the carrier may be quoting one risk, and then if you make a change and the enrolled census looks markedly different, there's a possibility that the premiums could change. That makes it very difficult as a part of this process. And then the second piece of this is something related to medical loss ratios as a result of claims lag. And not to get too technical, but you could understand this. So if in the month of March, I had 100 employees on the plan and they had claims, well, many of those claims in March for those 100 employees are not going to hit until April the next month. So we move into April, and as a result of COVID, a lot of lives are now off the plan, whether we laid folks off or just had a reduction in count in terms of enrollment. Now the premium coming in for those claims on 100 people might be 60 or 70. So now the premiums are reduced, the claims are the same, that results in a higher medical loss ratio. And again, at the end of the day, that's a negative impact in terms of marketing the plan and getting competitive quotes. So I could say for my book of business, the vast majority of clients are working within their existing carrier, taking a look at alternative plans, alternative portfolios, negotiating effectively with the carriers, because it has been made much more difficult to market plans. Ward and John, are you saying the same thing?
I have, Bruce. We're in a normal year, maybe 25–35% of our groups change carriers. This year, we're seeing very little migration to new carriers.
Okay, very good. Okay, so let's go ahead and move on and talk a little bit about the extended COBRA rules and special open enrollment. And I do hope that everyone on the call pays special attention to this. Now note, this is not legal advice, that is my disclaimer, but what I can tell you is that as a result of the changes to COBRA rules and special open enrollment rules, it really is going to create some administrative and certainly some cash flow challenges because of these new rules. And so the extended COBRA rules basically are often maintaining the same amount of notice days, but that count of days does not start until after the outbreak. So ultimately, a date is going to be decided upon in the marketplace, and it might be the federal government or the state determining what that date is. But let's say it's not out there until August 1st. So we're going to say the outbreak is going to be in place until August 1st, and then at that point, the clock starts. Now, the notice requirement to administrators is still within the first 30 days. The notice hasn't changed. However, the employees will have 60 days following the outbreak to make an election. So I'm sitting here in the middle of June. The outbreak's going to go until August 1st in my example. Now I have October 1st to make my election. That is a significant amount of time. Now the carriers are going to have to be required to backdate that because there can't be a loss in coverage. But you think about that time frame, it's substantial, and again creates an administrative nightmare. Now, let's say they choose to do that on October 1st. Now I have 45 days at that point to make an initial payment. So I think if my math is correct, I'm somewhere in the middle of December for a middle of June event. And during that time frame, there's a lot of things that we need to be concerned about, and employees are given an unprecedented amount of time to make a COBRA election. Now, the other thing to think about are those folks, and when we talk about cash flow challenges in particular, are existing COBRA members. So existing COBRA members have an extension in terms of making their premium payments to your administrator or to yourselves if you're self-administering it. And that existing COBRA member will have 30 days following the outbreak to make any subsequent payments. So again, if we're considering August 1st as the date, someone would not have to pay their May, June premium out until 30 days from August 1st or September 1st. Now, because they're actively enrolled in COBRA, they need to be maintained on the plan. And in theory, you'd also continue to pay their COBRA premiums on their behalf. Think about the risk involved in terms of cash flow and the fact that, ultimately somebody decides 3 months from now, because that's the amount of time they have in the example, that they're not going to make payment. So again, it's going to be an administrative challenge. There are some cash flow challenges. And then lastly, like COBRA, there is a new timeline in terms of events for special enrollments, special open enrollments. That's 30 days following the outbreak. Now, folks probably know on the call that the enrollment of a child in the state of New Jersey or a newborn has been extended to 60 days. That's not going to discontinue. But any other life event, again, if we're using August 1st, doesn't need to be communicated until September. That's giving folks a lot of time to decide what they want to do. And again, if they do decide to enroll, that's a significant backdating and other things that we have to be concerned about. So this is really creating some challenges. I do ask that you speak to your COBRA vendor or your current broker to talk about this in detail, just to make sure you remain compliant. And so I'm going to finish up talking about, again, the current state of affairs, and in particular, talking a little bit about telemedicine and virtual appointments. So right now, and this has been the case in a lot of instances, but all of the carriers pretty much are providing 100% coverage, not even a copay, for access to telemedicine. And the fact of the matter is, we are seeing a tremendous uptick in the use of telemedicine. And so for the last several years, I've talked to clients, I've talked to employees about this great opportunity to use telemedicine. And quite frankly, the utilization has been modest at best. As a result of the COVID-19 situation, we are seeing a tremendous uptick in telemedicine for obvious reasons, right? It's convenient, it's easy. I can do it on a cell phone, on a tablet, on a computer. I can actually see the doctor, he can actually see me, and it's covered 100%. Statistically, I believe the number is somewhere in the low 80s, so about 82% of the care that would be needed by someone calling telemedicine can be addressed over the phone, right? So that's more than 80% of the time. Prescriptions can be filled as well. So you might have an eye infection and you can get an antibiotic for eye drops provided right by the doctor through telemedicine. So I think that's a big change. The other thing is that there are no disqualifications of HSA rules. So again, just like we spoke about with 100% coverage for COVID, we don't have to worry about providing 100% coverage for telemedicine, and now I'm no longer eligible for a health savings account. Now, like telemedicine, and this one's probably the most interesting to me, is the expansion of virtual visits. So today, in terms of your doctor's office, I know in terms of my children, very often the doctor's offices are closed, but you can have a virtual visit. So just like telemedicine, you would call in, FaceTime with your doctor, and quite frankly, that might be your only option to see your doctor today. At the same time, generally today, doctors are accessible. Again, they will see you on a video. They can prescribe medications just like they could before. But the big difference here, unlike telemedicine where I can't necessarily choose the specific doctor I'm working with, in a virtual visit, I'm seeing my doctor, okay? So it's going to be interesting to see in terms of what that looks like in the future. I will say it certainly is likely to have a positive impact on future premiums. We may even see a situation where there's a sub-network that is literally a virtual network. And so rather than a $30 copay, you might pay a $10 copay for a virtual visit. It really is going to be interesting what we see in the future around this idea of telemedicine and virtual visits. And I do think, again, it will have a positive impact on future premiums. And I think that it's it's going to be a good opportunity for employees. And you could argue, well, my employees were kind of forced into telemedicine and virtual appointments. That may be true, but in the end, I've seen the groups that I've spoken with, the individuals, and even within my own family, have had a high level of satisfaction in terms of how they felt about those virtual visits. So again, I see this as a real positive outcome as a result of the virus. So lastly, I'm going to touch on premium relief. And Ward made the point a little bit about premium relief around the rebates, but I do want to differ in terms of a rebate versus a credit. So I mentioned Oxford in several of the past years has had a premium rebate. They were paying claims below what the Affordable Care Act said they should be, whether it's 80 or 85% MLR, and they issued a credit back to their clients. And again, as Ward mentioned, there are some specific rules around that. But with respect to premium credits, a little bit different. Some carriers are actually offering a medical premium credit, not a rebate, for the July bill. In the case of Oxford, up to 15% of your July bill will be credited. I think some other carriers may follow suit, and it'll be interesting in terms of what we see down the line. There certainly has been more payment flexibility, so grace periods have been extended by requirement, at least in the state of New Jersey, to a minimum of 60 days. Some carriers are looking at it a little bit differently. Dental carriers. I've seen carriers refund entire months, half of months. Some significant premium credits are coming on the ancillary side, and specifically dental. And in terms of renewals, we're generally seeing rate passes. I'm not certain that there's an ancillary carrier not offering a rate pass today, because obviously their utilizations are down. So, that's pretty much the impact that we're seeing at a high level with respect to the state of employee benefits as a result of the COVID-19 outbreak. And again, we'll have an opportunity at the end to ask any questions. But I'm going to go ahead and turn it over to John now, who's going to talk about the cost savings opportunities that might exist in the marketplace. And frankly, they're probably more important than ever. So hopefully we'll pay close attention. John?
Bruce, before we jump into that, John, one second before we jump in, I just want to add one thing to what Bruce said, and that is these premium credits that we're seeing are carrier-wide. It's not group-specific. So if they're offering a credit, it's going to be given to all clients and not specific to any one group.
All right, thanks, Ward. So I'm going to walk you through a couple cost containment strategies that came about through the survey results, and it was a poll taken directly from the NJCAR members. So some of the things that we're going to be talking about today are directly in correlation with why potentially some of your have been seeing pretty favorable renewals. And I think a recurring theme that we're going to see is a lot around consumerism and better healthcare decisions from the employees themselves. And what we need to do with brokers and employers is make sure that we're educating the employees that they have all these resources and they're utilizing their plans the most efficient way. So one of the first cost containment strategies that came out from the poll was controlling pharmacy costs and RX. And there's two different sides to do that. There's the employee side, which we'll talk about, and what you can do as an employer on a plan side as well. So what we need to do is educate your employees at all the tools and resources they have available. So one of the first things your employees should be doing is utilizing generic drugs whenever available. 89+% of all the drugs that are out in the market are generic drugs. Which means that a lot of the drugs that these employees are being prescribed, if they're prescribed initially a brand name drug or a non-preferred formulary drug, they should be asking their providers, is there a generic that I can be taking? Because they can save a lot of money right off the bat there. And anytime one of your employees is taking a generic drug over a brand name drug or a higher cost drug, it's obviously going to save them money, but it's also going to save the plan money as well. Mail order drugs is something that anybody that is on a maintenance, medication should be utilizing. They're basically going to be paying they're going to be paying 2 copays for 3 fills of those drugs. So your employees can save a lot of money on those types of things. Prescription coupons and discount cards, and same with prescription shopping tools, are a great resource. So pretty much all of the drug manufacturers these days are coming out with some type of coupon program. So the easiest way for an employer just to find those drugs is to do a quick Google search, and you can find a 10 to 90% off coupon for that drug. Same goes for discount cards. So organizations will have a discount card. You go and you sign up. You take that card to your pharmacy along with your script, and they'll pull that discount right off of it just by showing that card. You can find a lot of these coupons and discount cards from the prescription shopping tools, and I have a few, listed below with Needy Meds and GoodRx and Blink Health, and they're resources that you literally just go in, you type in, the prescription you're taking and the dosage, and a tool like GoodRx, what it will do is it will tell you what pharmacy has it the cheapest in the area. and ED Meds, you put it in there and tell you, what are the discount programs that are available for those types of drugs. So it's a great way for your employees to be able to find drugs at a cheaper cost and save them money and save the plan money. I mean, these are great resources for all employees, but especially anybody that's on a high deductible health plan or anybody that has moved towards one of these level funded or self-funded type option programs. It's going to save both the employee and the organization money. The last thing is the retail store discount program. So these are programs that are offered by Walmarts and ShopRites and Targets, where they are literally offering free medication sometimes, essentially get you in the door. ShopRite's a perfect example where they will offer diabetes medications completely free of charge. So you go in there, you can go get your metformin for free. And the reason they do these types of things is they want foot traffic in their stores. So they want you to come in the ShopRite, and they know that when you're in ShopRite getting your medication, you're going to buy, your bread, your milk, your eggs, and all these other things while you're in the store. So that's why they offer these programs. And a lot of employees just aren't even aware that these programs exist, and it can save a lot of money. On the employer side, so, typically organizations that are about 200 plus, it could be a little bit less depending on your situation. We'll see, significant savings by carving out the RX. So you carve out the RX and you utilize something that's called a PBM, or a pharmacy benefits manager. And what they do is they manage your pharmacy programs, and they'll build out the formularies and say, these are the formularies, these are the drugs that we should offer, these are the tiers, and they will build out the tiers of the preferred drugs and non-preferred drugs, and they'll go based off of the drugs that your employees are specifically taking and build out those lists, and within that list they'll develop some drug access controls like step therapy programs and certain drugs that they may just not offer. We might just eliminate or exclude that drug because there is effective generic drugs that are available out there. So not even make certain drugs available to your employees because there is effective drugs that are going to be a lot more cost effective. Bruce, do you have anything to add on the pharmacy RX savings side?
Sure. I think probably one of the key points to make, and you did an excellent job covering it in terms of what the opportunity is, and tied to that is the idea around mail order. So very often when I'm looking at a group, and if the group is large enough where I can see the data, I might see generic utilization of 85 to 90%. Fantastic, right? Because again, the generic drugs are less expensive. But often within that same group, the mail order utilization is not as high, and folks are still picking up their monthly supply at a pharmacy. Again, as a result of COVID, I think one of the positive outcomes is that many more individuals, members, enrolled employees are utilizing mail order for their maintenance medications for obvious reasons, right? I'm trying to avoid going into the pharmacy. I don't want to wear a mask. Whatever the reason is, ultimately, we're seeing an uptick in terms of mail order. And then the last piece that I would add on the employer side is a contract review. There's a number of vendors out there that will do a contract review. I always think of pharmacy as kind of the Wizard of Oz behind the curtain. And what's really happening for most pharmacy programs is somebody's back there switching up and down all these switches. And very often they're trying to offset a rebate promise with the actual cost of a medication. So there's a lot of opportunity here for the right size employer. But as John made perfectly clear, there's a ton of opportunity on the employee side, and that ties back to communication, as he mentioned.
Bruce, those are great points. And one more thing on the malware, like you said, is there's a lot of pharmacies out there now that are actually filling packs. So if you're on 5 different maintenance medications, you go to, say, like a CVS, and you're even seeing some of the advertisements on TV now where they're filling your day-to-day prescription needs. So you have one pack, you rip open your pack, you take your medications for that day. So they are continuously advancing these types of programs and making them very user-friendly. Okay, next slide, Ward. Lou, sorry. So one of the other topics that came out of the poll was developing effective wellness programs. And Bruce and Ward and myself, all had the same type of strategy where it has to be implemented in a very calculated and strategic way. So we developed it with kind of a crawl, walk, run type of rollout where, you want to start slow. So some of the first things to take advantage of are wellness and healthcare newsletters and things of that nature. And most major brokerage firms all offer these types of things, and the carriers themselves have an array of different information and wellness newsletters that you can push out to your employees. A lot of the carriers also offer wellness and rewards type programs. So, you know, one that I just rolled out was a United Healthcare program. It's called Rally, where your employees can just download an app, and then they just track certain wellness activities, if you will, right on the app itself, and they get points. And when you get a certain amount of points, you can buy things like gift cards and things of that nature. So it's just something that your employees can get behind and start doing that right from some of the carriers' already value-added systems that you're paying for in your premiums already. One of the best first steps for a wellness program is encouraging and incentivizing the annual wellness exam. The annual wellness exam is something that we always want to try to push the employees to get. You know, obviously they'll go and get checked out for that year, but what the doctors will also do is they will order all of the screens and tests that they qualify for their ages. So you get your annual blood work done. If you're, you know, due for a colonoscopy, they'll order you your colonoscopy, and all of the preventative exams are all done. You know, they're all free because preventative care is covered at 100%. So that's a good way to just get started, and you can incentivize the employees as something as simple as go get your wellness exam. We'll give you a Wawa gift card for getting your wellness exam. Then you move to the walks, you know, station. At this point, you really want to start to implement programs. So smoking cessation, you know, you obviously, you know, want to try to create a smoke-free workforce, weight loss programs, stress reduction type programs, things of that nature. So you want to start building out those types of programs on a higher level. And you want to incentivize these wellness activities. Obviously, you want to get people to you know, quit smoking, but start to incentivize them to participate in a smoking cessation program. And you can do it again through, you know, Wawa gift cards, or you can tie it to something like contribution strategies. So you get, you know, a penalty if you are a smoker, or you get a reward. I always like the reward, you know, kind of theory a little bit better, where, okay, if you are a smoker and you participate in one of these smoking cessation programs or weight loss programs, we actually will give you credits towards your contributions and your health insurance. Something that's always really important is conducting health risk assessments, trying to get an idea of the healthcare of your workforce today, and their idea and their see how they would adapt to, you know, rolling out full wellness type programs. So these things are a really nice way to gauge kind of where your employees are at currently and where you think you can get them to go by rolling out something that's a little bit more intense of a wellness program. The utilization of wellness coaches, so dietitians, nutritionalists, stress management programs, and financial wellness is one of the hot topics that's out there that is always very highly tied to stress and to mental health and things of that nature. So, you know, there's a lot of organizations that are out there that will come on site and build out individual, you know, nutrition plans for your employees. Stress management and mental health, I think, especially right now, you know, we actually even did a webinar for NJCAR a month or so back about mental health, especially in this time of COVID-19, where people are at home and trying to adapt to this, you know, new norm and a new lifestyle. So these are great things to take advantage of, where people come on site and build them out. And again, it all comes back to incentivizing your employees to get these things done. And the last part is to full out run. So completely outsourcing the wellness program, having a vendor system where they will have all these types of things that we just mentioned, the wellness activities, the wellness coaches, the programs with smoking cessation and things that your employees can participate in and earn points, and they can be tracked, reported. You can do challenges and build engagement. And what this does is it gets your employees really involved with these types of things, and you can actually start to track your ROI. The more people that are involved with these programs, hopefully, obviously, you're going to create more of that consumer-driven employee where they're going to make better healthcare decisions. They're going to, utilize the plan better. They're going to drive down your claims utilization. And that's really the goal at the end of the day for all these programs, is to drive down claims. The healthier the employees you have, the less they're going to be going to the doctor and utilizing the plan. And it's going to save the employee, both money, and it's going to keep them healthier. And you're going to see a lot of increase in not just healthcare costs, but I think in productivity all around with your employees. With the run, you go to full biometrics, which obviously you can include it with your vendor system. And then a lot of employers are doing full wellness fairs. So they're having a full day dedicated just to wellness. They go out and they have all their wellness vendors there. They will have them sign up for whatever system that they utilize. You'll have, the carriers on site. You'll have healthcare companies doing biometrics and things of that nature. So, I mean, really the goal is to be able to roll these things out and be able to track the ROI, because the key at the end of the day. So, Bruce, anything that you would like to add on wellness programs there?
Well, I think this is a great roadmap, recognizing that anyone's individual situation or goals, this is something that's highly customizable. And the second point is that a lot of the things that John is speaking about are available today from your carrier for free or from other vendors for free. And the last point I would make is it's often possible to negotiate a wellness budget, so a pool of money from your insurance company that will help you effectively implement and execute these programs.
Great point. Okay, so the next topic we'll cover is contribution strategies. We'll go through a couple of the different options. Obviously, the most popular contribution strategy that's out there is the percentage of premium strategy, where basically you're just taking the premium, you cover a certain percentage, whether it be 50, 75, 80% of the costs, and that's your contribution. So every year that if there's an increase of renewal time, the employer contribution goes up, and so does the employee. And you can do that straight, where you have that across all tiers, or you can tier that out where you have maybe I cover 100% for the employee, but then I only cover 50% for the spouses and family. So you can tier those types of things out. And then to drop down, you can even do things like spousal exclusions or surcharges, where if the spouse has access to a group health plan from their employer, you can either have them pay a little bit more or say that they are going to be available to hop on your plan. And you would need them to sign off on a form stating that they have access somewhere else, or they don't have access to a plan somewhere else, to avoid those surcharges. One of the strategies that a lot of organizations are moving to is a defined contribution. So defined contribution is where you are offering a set of money. So say it's $400 we're going to contribute towards the plan. And again, this could be straight or tiered too. So it could be $400 flat, or you could say $400 for a single, $800 for a family. And this way you have, at the beginning of the year what you are going to be contributing to the plan. This is a good strategy for budgeting and at the beginning of the year, knowing what your costs are going to be, because it's obviously defined. And then at the beginning of the year, you can say, okay, well, we were predicting a little bit of an increase. Maybe we bring that $400 to $425, $450, or whatever it is. But at this point, you still know upfront what your costs are going to be. The downside to those strategies is if you do have a large increase and you have this defined contribution that you've already stuck to, you are pushing the additional costs onto your employee. Strategy that's gaining a lot of traction, a lot of organizations are moving to, is salary-based. So, basically, however much your employees are getting paid and what their ranges are, is what their contributions are going to be tied to. So the goal is the lower wage earners of your organization are going to be paying less towards your medical premiums, and the higher earners are going to pay a little bit more towards their medical. So it's really just kind of to scale it. So it makes it a little bit more affordable for your lower wage earned employees. And that strategy is gaining a lot of traction. A lot of organizations are moving towards that more salary based to make it more fair for all of their employees. Another strategy is class-based. It's a little bit more, class-based is a little bit tricky. You want to make sure that it passes non-discrimination testing, you know, because you can do things with, you know, hourly versus salary, years of service, you know, even job titles. But the problem is you really want to make sure that this isn't, you know, leaning towards favoring the highly compensated. So that's really the goal, is when you're doing one of these types of things, you want to make sure you're doing non-discrimination testing, and that it's passing all the rules, because the last thing you want to do is roll out one of these types of programs to get yourself in a situation, you know, that can be favorable for your organization. So those are just strategies that we thought were, you know, some pretty good ones that are probably in use currently and that some organizations can move towards.
John, I wanted to mention that this is Ward. Before, the defined contribution is a really strong strategy when you're offering multiple plan designs. What you're doing is you're defining, as John said, how much you're going to contribute towards the plan, and if the employee wants the more expensive, the Cadillac plan, then they can pay extra for that. And if they want to take the bare bones, then they're going to pay less for that. But from a budgetary perspective, the employer knows what their cost is, regardless of which plan the employee selects. That's where defined contribution really gets traction.
I agree. Thanks for pointing that out, Ward. So the last contribution strategy, I'm sorry, not the last cost containment strategy that we pulled out of the survey results was the utilization of Medicare. So obviously any employee that turns 65 and older is eligible for Medicare. What we see is a lot of employees not taking advantage of the Medicare programs that are available for them. An employer can't do anything to encourage or incentivize the employee to go onto the Medicare plan. So you can't force anybody over to the Medicare plan. But what the employer can do is educate the employees of all the advantage of being on a Medicare plan. A lot of times going on to a Medicare plan is more advantageous to the employee. They just don't realize all the advantages and the additional benefits of moving on to one of these types of plans. You know, one of the things they could do is potentially get lower premiums. So, you know, they hopefully are, you know, could be paying less out of on their premiums, and then better coverage, so less out of pocket as well when they're utilizing the plan itself. So really what needs to be done is, you know, an analysis for these employees that are turning 65 and say, what makes more sense? Does it make more sense staying on the group plan, or does it make more sense to migrate onto a Medicare plan where I could potentially pay less money and have better coverage? It's not always the case. Sometimes the group plan is going to be the better choice, but a lot of times you will see that the Medicare plans are a better option. And the thing is, you know, they just aren't aware, and employers not doing anything to educate these employees as to what's available on a Medicare standpoint. Right off the bat, all of the employees, whether, regardless of size, and I'll talk in a second why that matters of the size of the organization, but regardless of the size, the employee should always be on Medicare Part A. And usually it's automatic for Part A, but it's completely free, and it's going to only enhance the benefit for that member. So if the reason that the employee count is important is because if an employer has less than 20 employees, Medicare is primary, and then the group plan pays secondary. So what that means is if they go to the hospital, Part A will pay first, and then the plan will then, you know, cover the rest of the portion. If you're over 20, then the group plan is primary first, and then the Medicare is secondary. But so if you have a high deductible plan, let's say it's $4,000 deductible, your group plan pays first, your Medicare Part A will cover that secondary part. So, you know, you always want to have Part A. If you're under 20, all of your employees absolutely should be in Part B as well, because Part B, it works the same way with the Medicare being primary for groups under 20 employees. So you always want to have Part A and Part B for if you're under 20. If you're over 20 employees, Part B, may or may not be, a good solution for your employee, that where the analysis kicks in, because what you really need to do is do the analysis and say, okay, Part A is free, Part B, you have a standard premium typically of about $145, and then you would want to get a Part C, which is the Medigap or supplement plan, and the Part D, which is prescription. You add up, all of those costs and all the benefits of them, and then compare that to whatever the group plan is offering. But without doing a true, analysis and education, to that employee, they really won't know what is the better program. So typically what happens is the employee just stays on the group plan. They're like, hey, I'm on this group plan already. It's easier. I know what I'm paying, and I'm just gonna ride this out. Well, the benefit of removing somebody 65 or older is it's going to increase the look of the census. So, when you're going out to the market or you're getting your renewal or you're shopping it around, the better, the census and the younger the demographic, the better the rates are going to be. And Bruce mentioned that earlier about when you're going out to the different carriers and getting quotes, whatever your current carrier has compared to the census that you're sending to some of the competitors could look a little bit different. So the more people that you get that are Medicare eligible, off of the group plan and onto Medicare itself, really could be advantageous to the employee themselves, but it really will increase the look of the census when you're going out to, shopping it or getting your renewals, and it will lead to, in most cases, better claims experience. So over the years, obviously the intent is to drop down the healthcare premiums because we're migrating employees onto Medicare. Bruce and Ward, do you have anything to add on that?
Just the one quick point I would make is that, you may feel it's a difficult conversation to have with employees, and, that may or may not be the case for individuals that are on the call. But I do think at a minimum, if you have C-suites who are Medicare eligible, owners perhaps that are Medicare eligible, certainly there should be a conversation with your consultants in regards to that, because the point is you can often have better coverage less expensively, and it's definitely an opportunity that exists out there that at a minimum should be explored.
That's great. At this point, Brian, why don't we open it up for questions if anybody has some questions from the audience?
Okay. I'll ask everybody, you can either type in your question in the questions tab, or you can virtually raise your hand and we will try to unmute you and let you ask your question live. If we have any, I'll apologize ahead of time that if we have any technical issues, we'll probably ask you just to type in your question. Also, in the interest of time, and so we don't repeat too much or get too far off on a tangent, if a question was covered, I'll ask the presenters to refer people to review either the slides or a recording of the webinar, both of which are going to be posted to the NJCAR website this afternoon. Also, if a question is very specific to an individual's circumstances, the presenter might ask you just to contact them afterwards, so we don't get too far off onto a tangent that's specific to one individual. That being said, I do have one question typed in here so far, so we'll address that one. Again, if anybody else has any, feel free to type them in or raise your hand. Can we as employers get a summary of the claims that are paid, whether it's for wellness visits or emergency care? I guess they're not looking for the specifics, but a breakdown of whether the visits were for wellness or for emergency.
So really what that's going to answer the question about the availability of that type of data, very often that's going to be driven by the insurance company's policies. So insurance companies may have a policy that I'm not going to release claims data unless I've had at least 100 or 125 employees enrolled over the prior 12 months. If the group is smaller than that and doesn't meet that qualification, the likelihood is, frankly, you're not going to receive claims data. Now, you did hear the conversation about level-funded self-insured programs, which quite frankly can go down to 15 to 20 lives. In a minimum premium program, which is self-insured, or excuse me, a level-funded program, which is self-insured, you can get pretty detailed claims data. So it may or may not be available depending upon your carrier and your current funding arrangement. But again, for larger groups that are self-insured or smaller groups that are self-insured, larger groups insured, smaller groups self-insured, that data may very well be available and should be requested through your broker of the carrier.
I'm going to give people another minute or two to type in other questions, but I guess I'll just to recap the meeting, maybe just ask each of the four of you, if you had to pick one piece of advice to give the participants, what's the thing that jumps out at you most out of everything we talked about today? We presented a lot of information. If they leave here with nothing else, what do you want them to remember? We'll start with Bruce.
We probably should have covered this in our pre-meeting. That's a good question. I think that, quite frankly, if I'm going to take a look, I probably would steer clear of the COVID information because I do think that that's somewhat of a limited time frame. But as John made perfectly clear in his presentation, for larger groups, if you have over 175, 200, 250 employees, you absolutely should be looking at your pharmacy program. There is tremendous opportunity there. And I'm sorry, John, if that's what you were also going to say. But at the end of the day, the pharmacy benefits create exceptional opportunity. I'll give you a quick example. So we had a client who was with Cigna on a fully insured basis. Express Scripts is their pharmacy vendor. We went out to Express Scripts directly and received a proposal where the pharmacy costs were reduced about 35%. So if in today's world, pharmacy spend is about 30%, and I can get a 35% savings, I just saved the plan 10%. Okay, that's the opportunity that exists out there. That's something that you need to talk about with your current carrier and broker. And again, you can see our contact information on the screen as well. We're certainly available to assist.
How about you, Lou?
I think the thing that we've learned over the last few years is that this is an evolving industry. I mean, we're bringing up new topics every year. We're talking about level funded a lot more than we were 2 or 3 years ago. People need to stay aware. They need to get informed to make sure they can make the proper decisions. Again, there's lots of different options out there, lots of cost containment options. We've talked about some of them today, but again, I think people need to stay tuned to make sure that they are up to speed on the latest available opportunities.
Great. How about let's go with Ward, and then we'll wrap up with John, and we do have one more question here. So Ward.
I would, well, I don't have a lot to add to that. I think the panel's done a great job.
Okay. How about you, John?
I would say I think the quickest bang for your buck is to educate your employees on Medicare. I personally think a great way to do it is do a group meeting about Medicare and tell everybody that's pushing 65 or 65 and older should attend this and learn about Medicare. This way it's a soft push to the employees and then let them speak with an advisor on a one-on-one basis. I'm sure there's a couple organizations on the call that are on age banded rates. If you're on age banded rates, you see how expensive those rates start to get when you're in your 60s and plus. So you'll see it immediately with anybody that has age banded rates, and you're going to see it pretty quickly if you remove anybody that's 65 and older from the plan and on the Medicare. You by that next renewal, you will see, you'll see the impact in it. So I would say education around Medicare would be my takeaway.
Okay, and we have 2 questions here, so we'll get those unless any others pop in, and then we'll wrap up. How will we know if we will be receiving a credit or rebate from our carrier?
So on the credit side, that should have already been communicated. In most instances, I know at least within my block of clients where a credit was available, that's been communicated. I would say there is a very, very strong chance some level of credit will be coming to you in terms of your ancillary programs, be it your dental, your vision programs and such. Pretty much all the carriers are offering some level of rebate, perhaps 50% of 1 month or some other calculation. On the medical side, specific to premium credits, not rebates for a moment, because we're talking about credits. In terms of premium credits, again, right now, Oxford United is the one carrier who's come out and mentioned these credits. And so that may or may not have been communicated to you. If not, it will be forthcoming because it's supposed to impact the July premium. Now, a little bit different topic is around the rebates. So that's an annual event that takes place. So a carrier will take a look at their block of business in a given size frame and determine whether or not they spent what they were supposed to spend in claims. And if not, they'll issue a rebate. Again, that will be communicated directly from the carrier or through your broker. And then those rebates do need to, and Ward made this point earlier, those rebates do need to be shared with employees based on the percentage of their contribution versus your contribution. And your broker, consultant, or again, you have our contact information here, we can assist you in terms of how that rebate must be applied.
Okay, and then our final question. Can renewals be done quicker than 60 days prior to expiration dates?
Oh boy, let me take that. We, as your broker consultant, we're really at the mercy of the carriers, because when you get over 50 employees on plan and you're no longer in that under 50 pool, normally the marketplace wants to see the renewal, because that is the indicator. And certainly when you're over 100, they want to see the renewal and the claims experience that the carrier provides. So we're really at the mercy of your renewal before we're going to get any firm rates. The carriers are not required to release a renewal before 60 days in the fully insured space. Now, sometimes we're getting renewals maybe not quite 90 days out, but we're really at the mercy of the carriers and what they're going to release. On the partially level funded plans, they're only required to give 30 days notice. So we're even being handcuffed more if those carriers are following the letter there that they're not releasing rates before 30 days. But even in the level funded space, I think we're seeing somewhere around 60 days notice. Bruce, I'd love to get your take on that also.
I agree with you wholeheartedly. I know it's not always recognized, but the carrier really is very often driving that timeline. And that doesn't mean that we don't request, renewals 90 days out, 75 days out, or for some larger clients, even further out, just to be realistic in terms of having the right opportunity to go to market. But at the end of the day, it does boil down to when the carrier is willing, able, or negotiated to release that renewal. I will say, the larger the group, so if we start to get above 200, above 250 enrolled, you could probably expect relatively safely to see that at least 90 days out. But as Ward mentioned, sometimes it depends on if you're self-insured, when am I getting my stop loss renewal? So there's a lot of factors, and I guess the final point I would reiterate is a lot of times we are at the whim of the carrier.
Okay, I mean, do any of the four of you have anything else to anything else to add before we wrap this up? No?
Good
right, well, let me again thank Bruce, Lou, Ward, and John, and also thank all the participants in today's webinar. That concludes today's webinar, and stay safe. Thank you.
Thanks, everyone.
Thanks.